In the first half of the 20th century, pathologists began to see that autopsied patients with myasthenia gravis were more likely than not to have abnormalities of the thymus gland. They had thymomas, thymic hyperplasia, and other types of abnormal thymic tissue. However, at this time, we lacked a clear understanding of the causal mechanism that underlied myasthenia gravis. In 1941, Alfred Blalock and colleagues took this clinical pathologic correlation a step further. They posed the question, could it be that whatever's wrong with the thymus is not an effect of the myasthenic process, but rather is causing it? Could the thymus be the source of the symptoms? So they removed it. They took 6 patients with normal-appearing thymic tissue, normal on ultrasound, and they surgically removed their thymuses. It doesn't sound all that radical nowadays, but let me remind you that we didn't even use perioperative antibiotics in 1941. And anesthetic strategies were also incredibly primitive, limited to inhaled ether and thiopental. Surgery was practically barbaric. Anyway, these 6 patients, they all survived. 3 of them, as a matter of fact, did incredibly well. They showed improvement in their myasthenia symptoms. Welcome back to Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come with it. I'm Jim Sigler, and this week on the program, we are replaying a program we put out in April 2017, a show that summarized the relationship between the thymus and myasthenia gravis and the data of the recently published MGTX trial. And it was the MGTX trial where we learned, once and for all, the benefits of thymectomy for myasthenia gravis when the thymus gland appeared normal by ultrasound, implicating it as the silent but the pathogenic substrate for the disease. Well, since then, the MGTX trial has recently published their long-term follow-up data from the original cohort, and we'll be going over that at the end of the show for you. But first, let's go back to April 2017 and lay the groundwork. Here we go. In episode 18, we talked about the antibodies seen in myasthenia gravis, but we really didn't go into the details of how a patient with myasthenia should be managed. So if you have a patient who comes in with weakness and you find one of those antibodies, what do you do? Should everyone get a chest CT scan? Should patients without a thymoma go for thymectomy? How do you treat acute flares of myasthenia? And how do you manage these patients in the long run? Welcome back to Brainwaves. I'm Jim Sigler. Today, managing myasthenia gravis. From steroids to surgery, we'll cover it all. So you've made the diagnosis. A positive acetylcholine receptor antibody. Whoopity-doo. What next? In managing myasthenia, I think there are 4 main approaches to treatment. Symptomatic relief with pyridostigmine, immunosuppression with corticosteroids. Alternatively, there are steroid-sparing agents like azathioprine. And lastly, surgery, meaning thymectomy. We'll get to that last because it's interesting, and I want y'all to hear about all the other things I have to say before we get there. Let's start by addressing symptomatic treatment. Our go-to drug, one most patients tolerate, is the cholinesterase inhibitor pyridostigmine. Because of the major cholinergic side effects, nausea, diarrhea, bradycardia, etc., most providers start at a low dose, 30 milligrams 3 times a day or so, and they increase as tolerated to 60 or 90 milligrams 4 to 6 times daily. Some of the best advice I've gotten in managing these patients is to think of when patients get their symptoms. Usually, myasthenic patients complain of more difficulties with double vision or weakness later in the day, so maybe you'll want to backload those dosing intervals, either by dosing the pyridostigmine in the afternoon or the evening, or using higher doses as the day goes on. The side effects, like I mentioned, can be dose-limiting. Most importantly, I think you have to watch out for bradycardia. But symptomatically, patients will complain of more GI distress from the pyridostigmine, which produces its effects at both nicotinic and muscarinic acetylcholine receptors. And these patients may benefit from a muscarinic-specific antagonist, something like glycopyrrolate, usually 1 milligram twice or 3 times a day, or hyoscyamine, 0.125 milligrams a few times a day. I like to imagine that treating a patient with pyridostigmine is like attacking the problem with a BB gun. It's not exactly a toy, it works, don't get me wrong, but it takes a lot of time to make a little bit of damage. A longer-acting formulation of pyridostigmine, Mestinon TS, 180 milligrams, is also available, It's like a BB gun that automatically reloads for you. You can use the extended-release prednisone at bedtime in patients with persistent, severe weakness upon waking. Most patients, like I said earlier, however, do better after a night's sleep, and they won't need the long-acting version before they go to bed. But if patients wake up with significant symptoms, you might consider the longer-acting formulation. Another nice thing about prednisone is that for your patients who can't tolerate oral agents, there's an IV or IM equivalent you can give, which is about 1/30 the oral dose. So 2 mg IV for a typical 60 mg oral dose. But like oral prednisone, it provides limited temporary improvement in symptoms. Since we're using the analogy of prednisone being like a BB gun, you can imagine your solution might backfire on you. Too much of a good thing can sometimes be a bad thing. One consequence of taking too much of a cholinesterase inhibitor, besides the nasty GI side effects, the sludge symptoms, and the bradycardia, is that it can paradoxically cause more weakness. And this can be tough to distinguish from a myasthenic flare. When weakness occurs from excess prednisone in these patients, it's called a cholinergic crisis, not a myasthenic crisis. I don't think there's a great way to distinguish a cholinergic crisis from a myasthenic flare using any laboratory test. You've got to rely on your clinical history and exam skills. Someone taking over 1,000 milligrams of prednisone a day, or someone who's taking much more than they'd previously been taking, would be the kind of person I'd worry about having a cholinergic crisis. And on history, you might expect more of a muscarinic toxidrome in addition to the weakness, so the patient may have more salivation, lacrimation, GI distress, and so on. Moving back to the treatment of myasthenia, if you want to attack the problem with something stronger than a BB gun, you tank your patient up with steroids. This would be like using a shotgun. And like a shotgun, which sprays a bunch of tiny metal pellets in all directions, steroids impact the human body in all kinds of ways, good and bad. Specifically, in myasthenia, corticosteroids act by suppressing T and B cell function, which are implicated in antibody formation and acetylcholine receptor degradation. But steroids can also cause osteoporosis, cataracts, insulin resistance, and hyperglycemia. They can negatively impact sleep, and so on. And when you start steroids in a patient with myasthenia, most providers do this pretty slowly. You don't want to up-titrate an oral course of prednisone too rapidly because it can cause transient but significant worsening of symptoms in 30 to 50% of patients. And this deterioration usually occurs within the first 5 to 10 days of steroid use. It's kind of unclear why this happens, but it's a well-recognized phenomenon. That being said, we use steroids because they're effective, and roughly half of patients will experience significant improvement in their symptoms on oral steroids, and about 1/3 of patients will experience complete remission of symptoms. For inpatients who are being monitored, many providers will start by using 1 mg per kilogram prednisone daily, generally about 60 mg or so. And in outpatients, you might start a patient on 10 to 30 milligrams a day of prednisone and increase by 5 milligrams per day every week until you get to about 60 milligrams daily. Steroids begin to take effect after 2 to 3 weeks and are maximally effective at 5 or 6 months, unlike prednisone, the BB gun, which works within 10 or 15 minutes, and it's maximally effective at about 2 hours, but it wears off more quickly than steroids. Eventually, however, you'll want to get your patient off the corticosteroids or get them down to much lower doses, like 5 or 10 milligrams of prednisone a day, because of the side effects. And you'll just have to see how the patient responds to a very slow taper once symptoms are under better control. There's not much advice I can give you on this, and this podcast is not meant for clinical decision making. And while steroids are great, they're like using a shotgun, right? High impact, pretty effective, gets the job done. The side effects are intolerable in the long term. Osteoporosis, diabetes, weight gain, gastritis, myopathy, cataracts, etc. You can't go on using the shotgun forever. So you need something more targeted, like a rifle. Only I'm calling this rifle azathioprine, or cyclosporin, or mycophenolate mofetil. Azathioprine works by inhibiting purine synthesis in rapidly dividing cells, like B and T cells. Cyclosporin inhibits the release of IL-2 and it impairs T cell activation. And mycophenolate works by inhibiting nucleotide synthesis, which also slows T and B cell replication. Now that's all well and good, but when choosing which of these steroid-sparing drugs to use in a patient with myasthenia, I usually consider what are the contraindications to therapy. For instance, a patient with chronic liver disease should not get azathioprine. It can cause hepatotoxicity, and this only makes pre-existing liver disease worse. We also check TPMT, or thiopurine methyltransferase, activity before starting azathioprine, because azathioprine is associated with a dose and duration-dependent hematologic toxicity. TPMT is one of the enzymes involved in the metabolism of azathioprine, so a defect in this pathway will increase the active metabolite 6-mercaptopurine in the blood, causing the hematologic toxicity and resultant myelosuppression. You don't always have to check the activity of this enzyme, but experts generally recommend checking it at least in patients with leukopenia. And leukopenia is bad for both azathioprine for this reason, and it's also bad for patients who want to start on mycophenolate, so you might go with cyclosporin here. Renal disease, on the other hand, is a contraindication to cyclosporin, so that takes you back to mycophenolate or azathioprine again. And compared to steroids, which take effect after a few weeks, these immunomodulators take months to years before patients really improve. Remember, these drugs are like a rifle being used by a sniper. To take out an army of disease will cost you quite a bit of time. And because we're comparing a rifle to a shotgun, it doesn't necessarily mean one's better than the other. According to a Cochrane review, azathioprine is just as effective as corticosteroids in treating myasthenia symptoms. We just like to use it in place of steroids because it's better tolerated in the long term. So what can you do as the provider to speed up the process while your patient's getting used to this long-acting medication? Well, as you probably know, there are acute and rapidly effective immunomodulating therapies you can use, which we often use for acute flares of myasthenia or for crises. These include plasmapheresis or intravenous immune globulin. Going along with a gun analogy, these therapies are like a raid, or an invasion, or a tactical nuclear strike or something. I don't know where they fit in the analogy chain, but it's getting pretty violent here. Needless to say, IVIG and plasmapheresis get in there quickly and they get the job done. As far as which one to choose between IVIG and plasmapheresis, the two are considered equivalent interventions, just like they are when you treat Guillain-Barré syndrome. You should also check out that episode if you haven't already, episode number 30, on how these different immunomodulatory therapies work. For the sake of time, we'll just skip over them for now. But let's say you're a pacifist. You hate this whole NRA analogy I've been building up. You've surrendered all arms, but you're not waving a white flag yet. What do? Well, it turns out thymectomy works extremely well in patients with thymoma. But why thymectomy? Alright, Jim here again, back in 2019. I think that about catches us up to speed. In the next half of the show, we'll dive into the details of the MGTX trial and the clinical implications it has for patient care. Don't go anywhere.
Hi, Brainwaves listeners. My name is Ray Price. I'm the director of the Neurology Residency Program at the University of Pennsylvania, and I also direct the Penn Neurology Board Review course, now in its 16th year. For those of you preparing for the initial or recertification examinations, you know this can be a stressful time, but it doesn't have to be. Our high-yield course has more than 50 hours of recorded lectures for you to review for up to 6 months before the boards, and 2 days of live or online case-based learning. Past participants have found this an excellent way to prepare with well-organized high-yield material and engaging lectures. And for those of you who prefer problem-based learning, we have over 1,000 board-style questions available to people who take the course. For Brainwaves listeners, we offer a $150 discount on registration fees if you enter the promo code WAVES2019. Just check out the website link in this week's show notes or Google 16th Penn Neurology Board Review. Again, the promo code is WAVES2019. That's WAVES in all caps, 2019.
Why thymectomy? Here's what we know. The majority of patients with acetylcholine receptor antibody positive myasthenia gravis have thymic abnormalities, hyperplasia in 60 to 70%, and thymoma in 10 to 12%. Furthermore, since we've been attempting thymectomies for myasthenia for at least the last 75 years or so, the neurologic manifestations of disease often improve or disappear after surgical resection. The thymus contains a small number of myoid or muscle-like cells. These cells express acetylcholine receptors on their surface just like your muscle cells do, and they're the only known cells in the human body to express this intact acetylcholine receptor outside of muscle. It's thought that these ACH receptor-expressing myoid cells may prime the helper T cells so that these eventually attack the ACH receptor and create infiltrating germinal centers in the hyperplastic thymus. Once the germinal centers are created, plasma cells divide and conquer, and as unique antigen-recognizing domains of antibodies are expressed, a subpopulation of B cells eventually produce antibodies to recognize the intact muscle ACH receptor. So all the machinery is there, and once the myeloid cell membranes, like the acetylcholine receptor, are recognized by T cells, it's only time before the B cells begin to realize this can be a target of antibody production. In patients with thymoma, regardless of the symptoms of myasthenia, thymectomy is indicated as long as the patient is an appropriate surgical candidate and so long as resection is feasible. So refer the patient to CT surgery. In patients with thymomas who are not good surgical candidates, either due to infiltration of disease or comorbidities that increase perioperative surgical risk, then radiation and chemotherapy is going to be your best bet. But the next most pressing question is, should patients without thymoma be referred for thymectomy? Well, I don't think we really knew this answer until last summer, 2016. Multiple older, smaller, retrospective cohorts demonstrated slightly higher rates of remission among patients who underwent thymectomy for non-thymomatous myasthenia. The first of these studies was published more than 75 years ago. But several other studies showed no clinical improvements in thymectomy, or that thymectomy was no different than the medical management in the long term. Finally, in a 2016 systematic review that had identified 22 of these observational studies of patients with non-thymomatous myasthenia gravis, those who underwent thymectomy were more than twice as likely to achieve remission than if they had been treated with conservative medical management alone. And these results were strongly statistically significant. But they paled in comparison to the international randomized controlled MGTX trial published in the summer of that same year. What the MGTX investigators found was incredible. For patients with acetylcholine receptor antibody-associated myasthenia, thymectomy in patients without a thymoma improved outcomes across the board at 3-year follow-up. Functional outcome, check. Compared to the medical arm, which received prednisone monotherapy, thymectomy was associated with a lower quantitative myasthenia gravis score. Corticosteroid exposure reduction, check. Thymectomy reduced the dose of prednisone necessary to achieve symptomatic remission. Requirement for additional immunomodulating therapy, check. Hospitalizations, check. Psychiatric disease related to medical illness, check, check, check. Each of these outcome measures improved with thymectomy compared to prednisone alone. But all these great things being said, I would caution your interpretation of the findings. Like nearly any successful clinical trial, strict inclusion criteria were mandated in order to homogenize the population. Patients had to have myasthenia gravis for less than 3 years, they had to be 18 to 60 years of age, and they had to have an elevated acetylcholine receptor antibody level. Patients with only ocular myasthenia were excluded. I should also mention here that the benefit of thymectomy is not immediate, as the results of the MGTX trial have proven. The investigators evaluated 3-year clinical outcome measures. The 1-year remission rate is less than 20% according to pooled data from older clinical trials, which is still okay. But over 7 to 10 years, the remission rate increases up to 50% with thymectomy. In conclusion, and to summarize the data, thymectomy is generally recommended by most centers for patients with myasthenia gravis as long as the following criteria are met. First, patients must have generalized symptoms. Ocular symptoms don't count yet. Second, patients must have ACH receptor antibodies. No MuSK or LRP4 or calcium channel antibodies, which we see in the Lambert-Eaton syndrome. And third, and this is probably a soft call here, the patients must be younger than 60, which really just means they should be good, healthy surgical candidates. Unanswered questions regarding thymectomy include the appropriate age for surgery, when it should be performed in the course of the disease, but earlier is probably better as long as the symptoms are significant enough. Another question is the surgical approach, meaning transthoracic or transaxillary. And lastly, the role of thymectomy in patients with seronegative myasthenia, MuSK antibody-associated myasthenia, LRP4 disease, or patients with purely ocular disease who are seronegative. So there's a lot to follow up on here, and the studies are ongoing. In sum, there are 4 main tactics for treating myasthenia. First, symptomatic management with cholinesterase inhibitors like prednisone. These increase the available acetylcholine at the neuromuscular junction, but the treatment can be limited by its muscarinic side effects. Second, immunosuppression with steroids, then steroid-sparing agents. which are limited by the long-term toxicities. They take months usually to kick in, unlike pyridostigmine, which can take minutes, but they provide good long-term control of the disease. Third, the acute management of flares, usually with IB immune globulin or plasmapheresis, which works over days to weeks, but has a limited lasting effect. And finally, thymectomy, which is indicated in patients with and without thymoma, as long as the patient has generalized myasthenia, acetylcholine receptor antibodies, and as long as they're a good surgical candidate. Fast forward now to 2019. It's 2 years later, and 2 years have passed since the original results of the MGTX trial. What I do want to mention, however, before we get to the 2019 update, are a few small details about that clinical study. First of all, it was only a single-blinded study. The raters were blinded to the clinical outcomes. Imagine yourself as a patient. You're told, hey, we've got this trial. There's a 50% chance that you'll be able to have a minor surgery that we think can improve your myasthenia symptoms and reduce the amount of steroids you'll have to take. Or you could be in that 50% who don't get surgery, and you'll stay on prednisone. What do you think the people who got the surgery felt like? And what did the steroid-only group feel like? I bet the placebo effect was significant. Also, let's consider the inclusion flowchart. 6,958 patients were screened for study inclusion, yet only 235 met criteria, 3%. Now, maybe that was just excellent work by all the trialists at screening the potential patients, and it does give us a sense of how many patients may exist out there who could benefit from thymectomy. But man, this is a pretty pitiful number. And when you take this number and you subtract another 105 patients who refused to participate in the study, and then another 8 patients in the surgery arm who declined surgery, and 8 more patients in the medical arm who got thymectomies, you're really cutting down on the number of patients who would have met a per protocol analysis. The original analyses were performed based on the intention to treat principle, which meant that you could have gotten the surgery, but you were analyzed like a medical patient. Well, what if your disease got a lot worse with time and with continued steroids, and you or your physician wanted something better, like a thymectomy? Wouldn't that patient's poor clinical status contribute to the poor outcomes observed in the medical arm? And what about the patients who were assigned to surgery who said, nope, not doing it? Maybe their condition improved on low doses of corticosteroids, and they felt pretty confident that their disease was well controlled. I don't need surgery, they'd say. And now the surgical arm is also a little bit buffed up. Next, think about how the MGTX trial included patients with relatively mild but disseminated disease. Patients were only included if they had generalized myasthenia, and not isolated ocular myasthenia. And they could not be included if they had a crisis requiring intubation, or if they were on a steroid-sparing agent. You would think that, although it's probably harder to adjust for the various non-steroidal therapies out there in the 2 treatment arms, that maybe these patients with the more severe disease would achieve a greater benefit, or at least we should be targeting them for more aggressive interventions. In addition to the mild overall disease from the MGTX cohort, a large number of patients were excluded on the basis of the age cutoff. They had to be between 18 and 60 for trial enrollment. This excluded nearly 3,000 screened patients, but it may have led to a more appropriately targeted group of patients, and epidemiologic data suggests that the odds of thymoma, or abnormal thymic tissue, fall dramatically after age 60. So chances are, if you're younger than 60 years of age, you're much more likely to have an abnormal pathologic thymus. Now those are most of my concerns. Let's also consider the pros and the cons to thymectomy. Pro: you could probably cut your steroid dose in half. Con: surgery costs $80,000. Pro: a few pills a day are easy. Con: surgery is invasive, and it's risky. Pro: your thymus is probably abnormal if you're younger than 60 and you've got myasthenia. Con: ultrasound is pretty good at detecting cancerous tissue in the thymus, so why remove benign tissue? So overall, it's not so easy to decide one way or another. And to give us more insight, the MGTX investigators worked harder to prove that their surgical intervention was at least helpful. At the end of the initial study period for MGTX, the investigators showed that the effect of thymectomy plus prednisone appeared to plateau along with the effect of prednisone. Benefits were maximal after about 18 months or so after surgery, and down the road, while the clinical difference remained, there was not much incremental improvement. And you'd think that, if you got rid of that pathogenic tissue, shouldn't you ultimately rid yourself of the disease? So what the investigators did in their follow-up study was they asked the 126 trial participants, 60 in the medical arm, 66 in the surgical arm, to return for a 5-year follow-up visit. Except they only asked 111 patients because 15 failed to follow up. And then another 43 patients refused. So now we're down to 68 of the original 126. And then 18 more failed to follow up, leaving 50 patients for a final analysis, hardly more than a third of the original cohort. And I already mentioned that half of the patients who were eligible for this study agreed to participate in the first place, so now we're boxing ourselves into a corner of selection bias even more. Let's move on to the results. As we saw in the original results of the MGTX trial, by 3 years there was a statistically significant improvement in every measurable clinical outcome with thymectomy over medical therapy alone. Steroids were cut by more than half, the average quality of life score improved, and the proportion of patients who required IVIG and plasma exchange was also cut significantly. At 5 years, we saw the same effect. But one outcome jumped out to me. While the proportion of patients who required hospitalization was far greater in the medical arm, 30% versus a mere 6%, the cumulative days spent in the hospital were identical, 26 days total in both arms. And these hospitalizations were related to myasthenic exacerbations. Interesting, but the authors don't exactly comment on this. It makes me wonder if patients without surgery were more nervous about their disease course, or they were on the higher steroid dose and they didn't feel symptoms were controlled well enough, or whatever it was, that they sought medical attention more frequently. And yet, their functional disability was similar to the surgical arm, because, well, we're just not going to hospitalize a patient without good reason. The total hospital days for myasthenia were the same. Ultimately, this study was important. It was designed to answer a question. Is thymectomy for non-thymomatous myasthenia helpful or harmful? And it seems like it was helpful. When I asked the neuromuscular docs that I work with, what do you make of the data? I'm told that everyone's excited about it, but overall it's a small splash. We're left with many other unanswered questions. What do we do about older patients with non-thymomatous myasthenia, especially since they may be less tolerant of corticosteroids? What do we do about the younger and the middle-aged group who present with myasthenia and they're naive to therapy? Do we take them to surgery from the get-go, or trial them on steroids? From a methodology perspective, the MGTX data gives us a lot of insight into the technical challenges of answering these kinds of questions. If it took 7,000 patients to find a treatment effect in fewer than 100, how hard is it going to be to design a trial that addresses these smaller subgroups? And maybe that's why there are currently no randomized clinical trials out there trying to answer the question. That wraps it up for our program this week. Hope you learned a little bit about thymectomy for the treatment of myasthenia gravis. The Brainwaves podcast is produced at a Studio 3 in Philadelphia, Pennsylvania. Jim Siegler, senior producer. Again, in case you missed the ad that was placed right in the middle of this week's program, if you've got board exams coming up this summer, really take a look into the Penn Neurology Board Review course. It's an incredible crash course for your board prep needs, and you can get access to question banks and hundreds of hours of online content, in addition to the standard live and in-person talks by Penn faculty. For Brainwaves listeners, you can get $150 off your registration fees. Just use the promo code WAVES2019. That's WAVES in all caps, one word, WAVES 2019. Music for this week's program was courtesy of Scott Holmes and Lee Rosevere. Sound effects by Mike Koenig and Daniel Simeon. I'm Jim Siegler for Brainwaves. Thanks for listening.